Good afternoon, everyone. Welcome. It is so great to have you today. Welcome to today's co-hosted webinar, calaim and ltss, Implementation Reflections and Opportunities. My name is Crispin Delgado, and I am Executive Director at Insure the Uninsured Project, or ITUP, as we're called often. ITUP is co-hosting this webinar with our friends at the California Collaborative for Long-Term Services and Supports, as well as Chapman Consulting, who will introduce themselves in a moment. I'd like to acknowledge that this webinar is made possible by funding from the California Healthcare Foundation. Before we dive into today's content, I have some important housekeeping notes for you. First off, this forum is being recorded and will be available on the ITUP Policy Forums webpage. Attendees can listen to this webinar through their computers or by dialing in using the number and the code that was provided to you by the Zoom software. We also welcome you to utilize the closed captioning function. Just click on the CC button at the bottom of your screen and to enable the live transcription feature. If you have questions throughout the forum, you don't have to wait until the end. You could simply click on the question panel at the bottom of your screen, submit your questions, and we'll try to answer as many as we can. And if there is a specific speaker that the question is aimed at, please include their name. Also located at the bottom of your screen is the chat panel. So please feel free to jump on there, introduce yourselves, your name, your organization. And, you know, it's also a great opportunity for you to chat with other people on the webinar. And lastly, we'll be posting relevant information and useful links throughout the forum. Post-forum, we will collect all the links that are shared throughout the chat as part of our follow-up message to you. For those of you who are unfamiliar with ITUP, let me tell you a little bit about us. So we've been around for 25 years. We started in the mid-1990s. And we're a health policy nonprofit and a convener. We have three core areas in which we do our work. As you can see, our mission is to promote innovative and workable policy solutions that expand healthcare access and improve the health of all Californians. ITUP implements its mission through policy-focused research and broad-based stakeholder engagement. ITUP believes that all Californians should have the fair opportunity to live their healthiest lives. And so I share this because I want to talk a little bit about the way we do our work. And so, you know, annually, we hold an annual conference in Sacramento, but we also run regional work groups to really hear how implementation is happening at the local level. And we also host 360-degree policy forums and webinars. Again, thank you for being here. And we publish in-depth policy issue briefs, as well as high-level health policy fact sheets. This webinar today is the culmination of 6 months of listening sessions aimed at identifying systemic challenges, gaps, and barriers, as well as best practices in service delivery to older and disabled adults. My colleague Maria will present on the findings a bit later. But our main goal with the listening sessions was to help strengthen the relationship between LTSS providers, health plans, and the broader health policy community by elevating the LTSS perspective and bolstering collaboration. In order to successfully move the needle on this issue, like many other issues, dedicated collaboratives and partnerships to preserve the well-being of California's older and disabled adult Medi-Cal and dual eligible populations. With that, it is my pleasure to introduce Athena Chapman, President of Chapman Consulting, and Mariah Kalina, Executive Director of the California Collaborative. Thank you both for your partnership. Let's go ahead and start with Athena, and then we'll go to Mariah.
Hi, it's Elizabeth Evanson with Chapman Consulting. Sorry for the last minute switcheroo, but happy to be here. Happy to have participated in the convenings leading up to this policy forum. And yeah, I'll pass it over to Maria.
Thank you so much, Elizabeth. Good afternoon, everybody. So excited to see so many people interested in this topic. My name is Maria Kalina. I'm the Executive Director of the California Collaborative for Long-Term Services and Supports. And we are a statewide membership organization with nearly 60 members working to advance the dignity, health, and independence of California's older adults and people with disabilities. Again, thanks for tuning in. I don't want to spend too much time kind of providing background information on calaim, but for anybody who's new to the conversation, and I think this is on the next slide, calaim, or California Advancing and Innovating Medi-Cal, is a statewide systems transformation plan aimed at standardizing managed care benefits and enrollment with a laser focus on providing person-centered or whole person care, addressing social determinants of health, improving quality outcomes, and addressing disparities. It's set to be implemented over the course of several years through the phase-in and refinement of various calaim initiatives, including a number of initiatives that went live at the onset of 2023 and more broadly impact California's Medi-Cal and dual eligible older and disabled adults. For this particular population, namely individuals with complex health and social needs, access to services and continuity of care is critical. And we know that with any large reform, there's bound to be bumps in the road. Our partners, members of the collaborative, ITEP and Chapman Consulting, believe there's tremendous value in not only identifying where and what those bumps are, but also in understanding and sharing best practices, in creating an opportunity for peer-to-peer connection among LTSS providers and partners, and ultimately having a unique space that can support and drive the collaborative development of resolution strategies. We recognize that calaim implementation is an evolutionary process. We're trying a new way of doing things, and through that process, we'll learn and hopefully adjust as we go to ensure that we do ultimately deliver on the promise of calaim. So we were incredibly fortunate to have the partnership of the California Healthcare Foundation and the support of the Department of Healthcare Services in launching a short series of listening sessions to hear from LTSS providers and partners across the state about their experience with calaim. And I'm really excited and honored to be able to join you today, sniffles and all, apologies, recovering from a cold, but to share some of our lessons learned. And by the way, for anyone who's interested in learning a little bit more about calaim, the California Healthcare Foundation and ITEP have developed some tremendously helpful and concise resources. So on this particular slide, there is a QR link that'll take you to California Healthcare Foundation resource, and I think ITEP and we can put our heads together and maybe outline a couple others that we'll share as part of the follow-up. Next slide. There are a number of initiatives in calaim, some of which focus on specific population and others that are overarching. The past 6 months of listening sessions focused on a few of those initiatives, more specifically those that impact California's Medi-Cal and dual eligible older and disabled adults, enhanced care management, community supports, and the intersection of providing access and transforming health, also known as PATH, as well as the statewide managed long-term care carve-in. The enhanced care management and community supports initiatives are foundational pieces in the Medi-Cal transformation. These two initiatives work to break down the traditional walls of healthcare, extending beyond hospitals and healthcare settings and into communities. They introduce a better way of coordinating care and provide high needs members with in-person care management where they live. For CBOs, public hospitals, county agencies, and other partners interested in calaim, PATH offers resources to support and build out the capacity and infrastructure required to fully participate in the Medi-Cal delivery system. Partners can leverage PATH funds to support things like additional staff, enhanced billing systems, to build data exchange capabilities is just a few examples. And lastly, I want to touch on the statewide managed long-term care initiative, which shifts the responsibility of covering and coordinating Medi-Cal institutional long-term care to managed care plans statewide. This initiative kicked off in 2023 by integrating both freestanding and hospital-based skilled nursing facilities, and it'll continue to be phased in over time by facility type. The goal of the statewide managed long-term care initiative is to better integrate care across institutional and home and community-based settings, as well as to make the long-term care delivery system consistent across all counties in California. And lastly, as equity is woven into the very fabric of calaim, we did hold a session that was specifically dedicated to this topic on the heels of a recent California Healthcare Foundation report that highlighted the unintended consequences of over-relying on cost and utilization data to identify individuals who may benefit from more comprehensive services. So that's a little background. Again, we'll try to share some more resources for folks who may just be learning about calaim, but I really want to get into some of our lessons learned on the next slide. I tried my best to bucket these out in a comprehensive way. Hopefully it doesn't feel like I'm bouncing all over the place just because there was so much that we heard and gathered from these sessions, but let's get into it. For CBOs and others onboarding to calaim, especially those that provide services outside of the traditional healthcare arena, the onboarding process has been particularly challenging as it was really designed through the healthcare lens. So things like language and questions and contract agreements are very different from what social services and other non-traditional providers are used to. And this has resulted in a very sharp learning curve and exhaustive administrative work, which has been particularly challenging for smaller CBOs. As a first step in calaim participation, it's important for partners to conduct an internal assessment to identify existing programs that align with calaim and begin to piece together their place in the kind of broader ecosystem, the impact on operations and capacity and infrastructure gaps that need to be met in order to meaningfully engage in the Medi-Cal delivery system. Many CBOs and non-traditional health organizations have existing relationships with one another. And so it's vital to ensure that the services offered by each organization are in sync and work cohesively to deliver care. There may be a situation where your organization may be designated as both an ECM and a community supports provider, but you may have clients that receive enhanced care management through another agency and community supports from you. So communication, inclusive of transparency and relationships, are critical to the success of calaim at every single step. And we heard that theme come up time and time again. I honestly don't think we had a single listening session where that wasn't woven in one way or another. For those starting their calaim journey, the Technical Assistance Marketplace, which is available through the PATH initiative, offers off-the-shelf resources that can support this initial planning phase. However, what we learned is that it's also somewhat limited in terms of offering the kind of tailored support some organizations need to get integration efforts off the ground. And without having completed the contracting process and having been designated as an ECM or CS provider with their local health plan, Organizations are unable to access more of the personalized resources and funds that would well position them for integration. For organizations that have gone through the onboarding process, we learned that having a designated internal staff member who is kind of assigned to lead the effort was critical in building out new delivery system services and fostering connections with managed care plan partners. It's very clear, based on what we've heard, that managed care plans are allies in this process. And CBOs that have been successful in contracting underscored time and time again how important having a relationship with their plan has been. Managed care plans have been helpful in navigating the complexities of calaim and guiding CBOs through the process of integration. And I think actually we're on the next slide. Sorry, I'm getting ahead. Thank you. In some cases, we learned that there's been success in collaborating with managed care plans on solutions to ensure the successful delivery of services. For example, there was a community-based organization in the rural northern part of California that was successful in being able to negotiate a higher reimbursement rate with their health plan based on just how far they have to travel to deliver services. It's important to recognize that participation in calaim is conditional and that it will evolve over time. Having these relationships and building common understanding of challenges, both at the plan and provider levels, will drive system improvements over time. But you have to know where to start, right? So one way to make that connection is to engage in existing communication channels, such as the regional path collaboratives, where managed care plans and ECM or CS providers meet to optimize processes and discuss best practices. Path collaboratives are not just for current ECM and CS providers, they're open to prospective providers too. And you can leverage them for support as you work to kind of move through the onboarding process. At the same time, managed care plans benefit from these and other forums by learning from CBOs who have deep understanding of the climate and culture of the communities they serve. So it really is a symbiotic relationship, having places to engage. Next slide. Again, communications. It can't be said enough that having strong and transparent communication and working in a collaborative fashion to improve processes is a key to the success of calaim. We heard about the need for stronger and more consistent communications across the board, from plans to partners, from DHCS to stakeholders. That communication is needed to ensure that there's access to the most current guidance or information, but also to ensure that there's clarity and consistent messaging on expectations. Many ECM and community supports providers expressed confusion on calaim policy guides and regulations and how to implement them in the regions that they serve. And we think that in the process of trying to offer flexibility, the guides and regulations are subjective and open to interpretation. And this has led to differences in policy translation across regions and among providers and managed care plans, resulting in what has been hesitancy and slower engagement in calaim, particularly from smaller community-based organizations. Adding to the challenge here is that the challenges that CBOs and other partners face often vary by provider type. And that further contributes to the lack of transparency in communication channels. Ultimately, there's just a need to create more uniformity, bolster coordination, and strengthen communications across the board. For those who have for those who are actively engaged in calaim, navigating the unfamiliar terrain of Medi-Cal coding, reporting, and billing has been a challenge. For organizations serving regions with multiple managed care plans, sometimes there's different formatting requirements for reporting based on the plan. And so clarity and more standardized guidance on the requirements of reporting and billing would be helpful in easing the transition. And I believe that's something that DHCS is actively working on, but would love to hear from Anastasia. The kind of standardized approach to reporting and billing would allow for streamlined data collection and more accurate reporting on the efficacy of calaim. Touching on the long-term care carve-in front, increasing uniformity in approval processes during contractual agreements between facilities and managed care plans will improve efficiency with transfers in and out of facilities. So as CBOs and managed care plans continue working together, it'll be crucial to continue to improve administrative processes and conduits of communication to ensure the populations being served are receiving whole person care, including social supports to reach optimal health outcomes. I think we're on the next slide. Aha, data and transitions. Data is pivotal to supporting outreach and enrollment, as well as care coordination. While there's an assumption made that as part of the contracts, managed care plans will provide data on eligible Medi-Cal members, participants identified that there are challenges with obtaining the timely, comprehensive information they need. Many newly contracted enhanced care management providers are experiencing difficulties identifying and reaching individuals in their community that are eligible for ECM services. We also heard from hospitals and other ECM and community supports providers about the difficulty of supporting care coordination without access to beneficiary information. That might include things like which managed care plan they're associated with, whether they're accessing enhanced care management services and who their provider is, what type of services are they already connected to in the community. There was discussion about the need for additional clarity on criteria for accessing certain services and which areas of the criteria are standardized versus at the discretion of the plan. On the long-term care side, participants identified challenges with obtaining data and information to successfully transfer eligible members to in-network facilities that offer accommodating care services. We heard that medical staff are having to make an exhaustive number of calls to facilities to find proper placement for individuals transitioning from the hospital setting. And it's not just about moving the individual to a skilled nursing facility, any skilled nursing facility, but also making sure that they have the support that they need in that setting. For example, you may have a beneficiary who requires oxygen therapy, but not all skilled nursing facilities offer oxygen therapy. So one recommendation that came up during the conversations was to have managed care plans provide this additional layer of oversight through verification, confirmation, and routine updates to their provider network databases, as well as just listing the services offered in facilities to add a little bit of clarity around that. And the challenge of transitioning folks out of the hospital setting has been compounded by various unanticipated challenges with reimbursements, payment delays, and continual reauthorizations, while Medi-Cal eligibility redeterminations and verifications were occurring simultaneously. I want to circle back to the data theme. Standardized data collection has been slow, and the lack of consistent data flow has resulted in difficulty accessing and extracting best practices. Participants on the listening sessions underscored the need for accurate data collection as well as a vital component of equitably identifying individuals who need calaim benefits and services to ultimately help improve health outcomes. And there's lots of room for innovation around data collection. As I mentioned earlier, we did have a session that was focused on equity in calaim, where we looked at a recent report from the California Healthcare Foundation. Historically, we've relied on cost and utilization data to identify beneficiaries, but we know that there's enough data saying that Black, Latino, American Indian, and other members of underserved populations may not be accessing healthcare as much as they need to due to a number of factors. This could be lack of trust in providers. It could be lack of available healthcare services in under-resourced communities. So by strictly looking at utilization data, where these populations are likely underrepresented, we're surely to miss individuals who may benefit from more comprehensive services and supports. And that does result in poorer health outcomes among certain racial and ethnic groups. What's needed is really a more holistic view of beneficiaries, which can be achieved by utilizing multiple data sources, including qualitative data that speaks to lived experience. So as managed care plans refine their approaches to determining eligibility, it'll be important to leverage the expertise of community-based partners who often have those deep roots in the communities they serve and can offer insights about existing or new data sets that can be used to identify individuals with complex needs. But the system would also benefit from just disaggregating data by race and ethnicity and other metrics, sexual orientation as an example, to understand the scope of disparity, to develop targeted solutions and track progress on equity metrics over time. Calaim, as you all know, is a very complex systems level transformation, and the way that we communicate it in policy forums or amongst our colleagues is doesn't translate to beneficiaries. We found that many beneficiaries are largely unaware that California is in the midst of a monumental transformation or of new benefits that may be offered to them through Calaim. And this really hinders their ability to self-advocate and meaningfully engage in the system. We can't really achieve whole person care without the person, right? So in order to center equity as a core principle in health and social services care delivery, we have to operate in a way that includes an emphasis on the beneficiary perspective, particularly of beneficiaries from underserved communities. And to meaningfully engage beneficiaries, managed care plans need trusted partners in the community who are well positioned to engage directly with consumers. That could be faith-based institutions, libraries, food banks. CBO partners are particularly well positioned for this role and can help to bridge the power imbalance. However, what we're hearing is that many CBOs are challenged with prioritizing equity while simultaneously working to build capacity and addressing procedural barriers and just adapting to new processes. And so I think it's important to keep in mind that Calaim really is a multi-year effort. It's an immense lift for all involved, and building a responsive and equitable system doesn't just happen overnight. So progress, it'll become better over time so long as we place emphasis on the communication, the compassion, that we look to recognize the various factors that influence implementation, like historic workforce shortages, compounded by burnout. And I think the other component to this too is that in order to build an equitable system, we have to be intentional about building an equitable system. That means being intentional about investing in an equitable system. So there's lots of food for thought just based on the information and lessons learned that we've collected through these listening sessions. And I really hope this well positions our panel of stakeholders for a robust discussion. So I think I'll turn it back over to Crispin.
Thank you, Maria. And I welcome my panel to start jumping on the webinar. As we get together here, I want to make sure I share that Calaim is a wide sweeping transformative initiative intended to help improve the healthcare delivery system by uniting both social services and healthcare to address social drivers of health and bring whole person care to life. As we approach year 2 of a 5-year plus initiative, major reform, it's important to reflect on California's progress as well as the challenges we face so far and the continued opportunities forward. So examining the unique challenges and barriers that are just faced by older adults and those with disabilities, and elevating what those implementation experiences are, so that we can help identify solutions and drive towards positive outcomes for this population. And so in welcoming my panel, a couple of things. So one is this is meant to be more conversational, fireside chat approach. But you imagine that there's an extra chair here for you, for all of you on the call to engage with us. So please feel free to put your questions in the Q&A box at the bottom of the screen, and we'll get started. So let's just start off quickly with each of you just introducing yourself, your role, and your organization. Meredith, let's start with you.
Good afternoon, everyone. I'm so pleased to be here. My name is Meredith Chalimi. I'm the Director of Regulatory Affairs with Leading Age California, and we are an association of over 700 nonprofit providers that provide care, housing, and services across the continuum. So we're so happy to be here today.
Great, thank you. We're so glad to have you. Tiffany, do you want to go next?
Yeah, hello everybody. Good afternoon. My name is Tiffany Wincho and I am with Justice and Aging. We are a national advocacy organization that works to improve the lives of low-income older adults. So we focus a lot on the programs that serve older adults in Medicare and Medicaid across the country, and of course, Medi-Cal in California.
That's great. Patrina, would you like to go next, please?
Hi, everyone. Happy to be here with you today. I'm Patrina Croysdale, and I am the Senior Director of ECM and Community Supports for Housing at Partners in Care Foundation. And our agency is a nonprofit community-based organization that focuses on the social determinants of health and bridging social services in the healthcare system. And we've been involved in ECM and calaim since the beginning of its policy development, the Health Homes pilot, and we're really excited to be here today with all of you.
Yeah, we're so happy to have you. Patrina, I'm going to start off with you. What strategies has your organization used or seen to effectively implement or to connect people, consumers and providers to better understand the calaim benefits? And how can outreach help increase knowledge, referrals, and access to these benefits?
Yeah, great question. So I think calaim is such a large initiative, and we all have the goal of, widespread outreach to such a vast amount of people, right? And so we have leveraged at Partners in Care some really efficient, fast, widespread approaches, such as using our engagement center, which we can reach out to people telephonically, and that helps us to reach thousands of people very quickly. So that has been a really good approach for us, but we also have we remember that we're working with people at the end of the day. So we have to also use tailored approaches, as Maria mentioned earlier. So we've done things like street outreach and text messages for people. Some people prefer mailing. And so I think just using a combination of really tailored, customized approach for some people, and then also those more technology-based approaches that helps us to reach larger quantities. So that has been something that has helped us. We also have been partnering with medical groups and hospital systems to really sit at the table together, right? So with technology now, especially after the pandemic, it gives us the opportunity to use systems such as Lanes, Find Help, et cetera, to sit at the table together and create an extended interdisciplinary care team. So that has helped us to bring more awareness into the healthcare system about what calaim has to provide.
That's great. Thank you. And I can personally appreciate that work, as I had 100-year-old and 101-year-old grandparents that my parents took care of. And so I understand the care coordination that's required. It's almost like you become a pharmacist, a caretaker, just all the different roles that they have to play. So seeing that someone can unite them with social services is great. Meredith, my next question will come to you. What do you see as the biggest challenge in access to timely care and continuity of care? In your work, have you seen any examples or ideas for solutions that can be used to, help close the communication gaps amongst hospitals, skilled nursing facilities, long-term facilities?
Well, those are really great questions. I think that I have to echo a lot of what Maria shared earlier. For our nursing home and housing members that are participating in calaim and senior living providers, they've had to have the challenge of really getting into this managed care world for the first time as well. A lot of nursing homes have been operating in the fee-for-service environment that are not in the CCI counties. And so they've had a big lift in terms of staff training and preparation and really becoming more complex administratively in order to contract with managed care plans. I would say another challenge that we already heard about today, but in the long-term care world has been coding and billing. It is different plan to plan, county to county. And so that is something in terms of the solutions that we're looking for more uniformity from the state, that it would be easier for our organizations that are providing these services to older adults to have that uniformity. So that things are less complex and more simplified on the administrative front, because really we want to be spending as most time as possible on direct patient care and resident interactions. And then I would have to also say that payment has been a challenge. In the fee-for-service environment, our nursing homes were receiving payments every 2.5 weeks like clockwork. And as we're having some of these growing pains that we're solving together, payments have been out 45, 55, 60 days, which is hard for nonprofit nursing homes to be able to sustain. So that's something that's getting solved over time, but has been a pain point. And then I would have to say also, just more on the solution side, these conversations are going to be so important going forward as we grow together. We would love it if we can have a quarterly, somehow ongoing stakeholder meeting by maybe provider type with DHCS and the managed care plans and providers, so that we can continue to problem solve. We think that's going to be really important. We all have best intentions, but we need to continue to iron out some of these wrinkles.
Absolutely. Thank you for that. Tiffany, I'm going to come to you next. Calaim has a focus on improving equity in the Medi-Cal healthcare delivery system. What are the next steps that you'd like to see in the coming years to ensure that communities with known health disparities and properly prioritize and have access to ECM and community supports?
Yeah, I mean, that's a great question. First, I'm encouraged by the findings that we've seen so far in the data that's been released by DHCS and the plans, because clearly plans are offering, quite a few of the community support benefits in all of our counties. And ECM, there is, an uptake. There is utilization that is being had for both of these services. So I'm very encouraged by the data that's been released so far. Of course, we still have the shared goals that all members who need these services are getting them. So I do think that there's still some steps that need to be taken and some targeted strategies and policy changes needed to ensure that older adults and people with disabilities are receiving these benefits. I think from what we've seen in the data, it shows that about 22% of dual eligibles are getting community supports, but that's about 1 in 5 dual eligibles when you consider the total population. So that does seem a little low considering the goal of community supports itself, especially those relating to transitions and housing. When you look at the context that older adults are the fastest growing age cohort experiencing homelessness. But of course, I know that we are looking at 2022 data, so very excited to see the numbers for 2023, given that, we are seeing, new plans entering the market, and well, that's 2024. But given the fact that ECM did have 2 new population of focus groups that did focus a little bit, that do focus more on the transition populations for those in nursing facilities. But I think there are still some things that are needed, such as additional data and analysis. I'm sure you've heard Justice and Aging talk about data and analysis a lot, but there is still a need for additional stratification and intersectional data. And that's just to show us a more detailed idea of who exactly is receiving services under each community support. So for example, older adults that are age 65 and older and that speak a primary language other than English, and if they're receiving community supports and in what number, or Black older adults that are 65 plus and receiving community supports, and even dig deeper, layering location in there, because we do know that there are disparities for people that live in more rural communities as well. So we think that's important to analyze, whether ECM and community supports are reaching particular demographic groups. And of course, while reporting data is that first step, also making sure that DHCS and health plans are analyzing that data and developing strategies to address any disparities. And then lastly, I know that, one of the key principles of calaim is uniformity and standardization, and there has been, progress towards that point. But the very nature of community supports goes against that principle, since they are optional for health plans to offer. And we are seeing from the data that while, there was a large number of community supports that were taken up, there is variation amongst the counties. If you were a dual eligible in Mono County, you had fewer options than a dual eligible in Los Angeles County. So from that very outset, the policy decision to have community supports be optional does allow these services to increase inequities and access, depending on where you live and what health plan you happen to be enrolled in. And that gets, very complex, because now you're having to decide on your Medicare choices as well as your Medi-Cal plan choices, and really looking into, what are those community supports that you are going to get access to. And there's a lot of self-advocacy and know-how that's involved when we're dealing with such a complex program across the board and throughout the state. But always a lot to say, but I think some of those next steps that I would love to see in the coming future.
No, thank you for that, Tiffany. I want to acknowledge that originally when we set up this panel, we did purposely have a representative from managed care on the panel. Unfortunately, I hope that they're okay. They did not make it. But if there are other people representing managed care plans on the call, if you want to respond to anything, please just let us know in the chat. We're happy to make space for that. Before I go to audience questions, I have another question for you, and this will be for all three of you. What recommendations can you share on how you build relationships and trust with the Medi-Cal system and its contracted managed care plans within communities?
I can go ahead and go first.
Thank you.
So, in thinking about this question, I go back to one of my guiding principles as a social worker, which is using the ecological systems theory, which basically says that the community member, patient, client, however you want to refer to them, is at the center. And every system that they interact with has an impact on their care and their health outcomes. And what that means is that how we as systems interact with each other impacts that person, and they feel if we are interacting with each other in a positive way or if there's tension. And so for me, especially with all of us being on, webinars and platforms like this, there's no difference for me between a coworker within Partners in Care Foundation and my coworkers over at the managed care plans. So I see us as extensions of each other. And I think, bridging those gaps of communication, and if I have a positive working relationship with my friends over at the MCPs, the participant of ECM or community supports is going to feel that, because they're going to see that we work more efficiently with each other, that there's not a lot of red tape. When there's an issue, we wrap around them and make sure that they're taken care of. So I think it starts with us and the relationships that we have with each other, and then just, creating that awareness within the community. So I think that, that for me is the best starting point.
Absolutely. And I know Tiffany mentioned data, and I think along with data, it's also narrative, right? We're changing minds and hearts as people approach these issues. Anyone else want to take a stab at answering? Yeah, Meredith.
I was going to share that I think that the Path Collaboratives have been a really successful kind of model of how to communicate in the best way possible with interested parties, with the health plans, with current providers, with others in the system. And I participate myself in 3 of them on behalf of Leading Age California members, and they are just, they're outstanding, actually. I think that that's been a real success. My suggestion is to expand those collaboratives to include other long-term care providers so that they're able to listen in, to provide their insights, and so that we have even more of those connections with everyone in the room. Example that we had recently was we have 2 residents that are ready to leave a nursing home and transition with that community support. And I was able to connect them in our membership with an ECM provider that's able to offer that service. So I would like to see more of that kind of happening structurally, but also on a big level so that we're evangelizing that these opportunities are available and we know how to make them happen.
I'll just
Yeah,
step in
please.
quickly just to add on your comment about the narrative and framing. I think part of that too is consistency. I think consistency amongst the state, amongst health plans, advocates, community-based providers, because it should be a seamless system. So having, the same information be shared amongst these various entities reduces a lot of the confusion that I think happens when you're getting different answers or different information from different sources and when they conflict. Because then, how do you know what to trust and who to go to? And another idea is also, I think, even similar to what the collaborative is doing with listening sessions, but also having that amongst individual communities as well, to gain insights on how to build that trust and what the barriers that are happening. And of course, compensating people for that, because there is a lot of time and preparation and time away from loved ones or employment to participate and provide that valuable feedback. And I think that should also be reimbursed in recognition of what is being offered.
Absolutely. Thank you for that. And, that's something that we also try to do through our 10 regional work groups. But I understand all of this happens at the very, very local level. And so just, being able to convene people to share what they're learning with other regions, as well as with state policymakers. I'm going to take one question from the audience. This is from Dr. Lindsay Yorman, Chief Geriatrics Officer at HHSA. Go figure. I'm bilingual. Spanish from my first language. Some of these acronyms are hard for me to say. So she says, I'm on a steep learning curve, and my impression so far is that health plan leadership does not believe that investment in ECM and community supports will have a return on investment, save them money. Even if it's obvious to many of us that focus on drivers improves health, prevents bad outcomes, saves money, to what extent are we providing evidence to health plan leaderships about the cost effectiveness of good care coordination, ECM, and social drivers, CS? And the second part of that question, so that's about what kind of evidence can we share with health plan leadership? And the second is, how can we engage with health plan leaders around this topic and give them the evidence they need about ROI and the level of detail they need, et cetera. Does anyone want to take a first stab at that?
I can. I have the pleasure of serving as an advisory board member representing seniors at CalOptima Health in Orange County. And not speaking for all the plans, but for CalOptima Health, they are very engaged, very excited about ECM and CS. They are investing heavily in both programs. And so at least in that pocket of the world, things are going well. The health plan wants to see this transformation and they believe in it very strongly.
Great. Patrina or Tiffany, anything you want to add?
Sure. So I have a lot of involvement in LA County, Inland Empire, and San Diego and Santa Barbara counties. So my experiences too, like Meredith, has been quite positive with the MCPs, that they have been very engaged. One thing that I will say is, because ECM is still fairly new, we've been putting a lot of time and energy into building out the structure of the program, making sure that it's running smoothly. But I do think that we could do a little bit more to, demonstrate the return on investment. So I think that that's something we definitely should focus on in the upcoming year. I do think that some of the efforts to see true change in people people's health outcomes will take a little bit longer than expected, because when you actually start working with people, their situations are a lot more complex than the average person thinks. So there's just a lot to dig through and try to figure out. So that has been my experience so far.
And that goes back to the data that we're all seeking, that is going to be more and more available, hopefully.
Absolutely. Tiffany, were you going to share something or?
No, I think just iterating. I would also love to, not to put Anastasia on the spot, but also the perspective of DHCS and what they're telling to health plans as well. But I think, as Patrina also mentioned, but and in the chat about, health plans sharing with each other the successes that they've seen and the return on investment that they've seen as well as those challenges to help make sure that, we are achieving some of those uniformity goals throughout the state, and plans are continuing to take up and offer community supports.
Absolutely. I know Anastasia will be on a little later, and so hopefully that will come back again. Let's see, I have another question from the audience here. An issue that I'm hearing some CBOs running into are bottlenecks, with local county eligibility offices running behind on processing Medi-Cal applications and providing an approval or denial, ultimately having applications incorrectly denied due to procedural reasons. Are there any best practices to working with the local eligibility divisions to avoid applications being denied or for procedural reasons, or to improve communication so that CBOs can better provide enrollment support to older adults while running into these bottlenecks? So basically, how can we streamline and avoid people falling through the cracks?
Yeah, I think that one of the hard things about the calaim timeline is that, obviously it's overlapping with redeterminations with the Medicaid unwinding. So that is a tough thing. I know that a lot of our organizations like Leading Age California are part of the DHCS ambassadors. And our members are as well. So we're trying to get information out to older adults and people with disabilities so that they have their address updated. They know to look for the yellow mailer that they're getting. And then locally, a lot of the health plans are supporting navigators that can come and help people if they need additional support filling out that paperwork. So those are some of the things that I'm seeing that are most helpful.
Yes, thank you, Mary. And just a reminder that they're not always yellow. I heard the state ran out of yellow envelopes. Sometimes they're white, but we just say be on the lookout for a packet.
A packet.
Yeah. Anyone else want to share some best practices? That was a great example. Thank you, Meredith.
I think this is also I think a question that also illustrates the very siloed and very complex nature of Medi-Cal, because we have the health plans delivering services, but then you still need that eligibility, and how that can create barriers to care for people that are eligible or because of the renewals being terminated for procedural reasons. I think I can say, at least from my experience when I was a direct services provider, is building relationships with the county as well. It is dependent on the county, but some counties do have liaisons that work with community members that can be very helpful with fixing some of these procedural problems, or at least provides a line of communication between the county and a community group as well. So that can help with fixing some of those bottlenecks, especially if you're seeing, large numbers of people that are being denied or terminated due to a procedural reason as well. But yeah, it's a hard one.
It definitely is. I did some of this work locally too. So I worked for San Mateo County, and worked on issues with the aging adult population. And it's just, it's not just a matter of what's available in the county, but again, how do we track the dollars to make sure that we could pay for it and that it's all seamless? And it sounds like a simple approach to things. However, we know that there's challenges all the way along that path. Let me see. There's another question here. With the huge focus on advancing equity in care that calaim promises, how is cultural competency, I like calling it cultural humility, and anti-bias training being rolled out to providers? And then lastly, the institutional inequity of bolstering the nursing home industry is very problematic. Are there efforts to bring independent living centers and disability advocates to the table and compensated to better inform care coordination and supports in the community? Let me open it up, see if there's Meredith. I see you're off mute.
No, I think that one of the things that comes to mind, another forum that's helpful is the ADRCs, the Aging and Disability Resource Connections. They're available in more and more counties where people can come together and talk about these matters and this equity. I know that California continues to focus on rebalancing so that whoever wants to can get home and community-based services rather than institutional care. That's something that we're very much in favor of. And that kind of ties back to what we were mentioning earlier. We need to have more time and effort spent on these nursing home diversion and transition programs so that people of all ages that want to leave the nursing home can do so with the ECM and the CS supports that are now available.
I can answer a little bit about the cultural humility, cultural competency piece. I too prefer cultural humility. So one thing that I can say is, especially with ECM having specific populations of focus, there's a lot of training that has been provided on each population of focus as it's rolled out, and really some best practices on working with certain communities or people that have, faced certain challenges in their life. So I think that that's one benefit that we've had in ECM that I didn't necessarily see in the past with the pilot version of the program. I would also say that, for partners in care specifically, some of our best practices that we've implemented is hiring staff with diverse backgrounds, with lived experience, who come from multiple different communities. We try to hire staff in the communities that they are serving. So we do a lot of, kind of matchmaking within ECM specifically. And, diverse languages. I heard Tiffany mention languages earlier. So that's another really key piece of that, especially translating your mailing and all of that. So I think that that's all to be taken into consideration. But as all of us know, there's so many elements that we all still have to learn. So I think that there's still a lot more learning to do. I think also, implementing additional questions into your assessments if possible, like asking people what are their pronouns that they identify with, and asking them if they identify as being a veteran, and just different questions that can help you to tailor your services and resources, and also just respect the people that you're working with. So those are some of the things that we've implemented.
Great, thank you so much. And I think that with that data and really understanding the whole person as they come into the systems is critically important. When I had first started that work in San Mateo, there was a case on the East Coast of someone who was GLBT and going into a nursing facility, and other older adults felt uncomfortable. It was a different generation. They were not open to having that person, and they ended up isolating that older adult. And so I think that there are some lessons learned nationally too, of like how we meet people where they're at and what they need. I'm curious, what is the outreach plan to educate dual eligible residents about Medi-Cal features and benefits? Have you guys, any of you tackled that so far? About the Medi-Medis?
And I can't say we've tackled it and that we found a solution, but I do think that is a problem that we see, because when you have two sources of coverage, there's supplemental benefits that Medicare might be covering, that we have Medi-Cal benefits, we have these Medi-Cal community supports, but there is a lot out there, and it's hard to, I think, create simplified materials that really explain the full array of benefits that a dual eligible might be eligible for. But I do think that for community supports and ECM, there are, a need for targeted strategies just to make sure that dual eligibles are getting access to these services equitably, especially when you think about, for a lot of, for dual eligibles, Medicare is going to be their primary source of medical care. It's these wraparound services that Medi-Cal is providing this group. So it can get complicated, and making sure that the Medi-Cal plans itself are also accounting, for that fact in their assessments. I think that, having the state and health plans create materials that are more standardized and uniform can also go a long way, just to make sure that there's the same message that is being put out by, both entities, and that is, more targeted to dual eligibles itself, and takes into account the fact that they still also have Medicare, and what that means for this group in and of itself. But I think that is something that the department is doing, is trying to, figure out these outreach strategies.
Yeah.
I think we have a long way to go, agreeing with what Tiffany is sharing. I have so many people on a weekly basis say, oh, I didn't know that was available. So obviously, one person at a time, whenever we can share, that's powerful, but we do need these overall branding and marketing initiatives so that more people know the things that they might benefit from that can help them to age in place.
Yeah. And I know earlier we heard from Katrina around, having, I was curious, like what do you call the roles where you said that people that are helping connect to the services, what are they considered patient navigators, or what do you call them?
So for us, we call them care coordinators. That's our primary position that works with the members themselves for ECM, but we also have developed some specialized roles, including a hospital navigator who specifically focuses on transitions of care and looking at our ER and inpatient admissions. And we also have a SUD navigator for those who have substance use disorders, and she has lived experience and has, worked with them. And then of course, for community supports for housing, you have your housing specialists and navigators as well. So that's the positions that we have.
Awesome. And going to Meredith's point, are they aware of like the full array of services that are available, or benefits that are available to them? Or how are there any insights that you would share for other people wanting to do this work around how they keep up to date with those benefits and being able to communicate it to people? That was for you, Katrina. Or Meredith.
I'm sorry, I thought I heard you say Meredith.
I'll say something and then pass it to you, Katrina. Leading Age California also has a lot of affordable housing organizations in our membership. And this is something that service coordinators do on a regular basis, connect the residents in affordable housing to calaim and the benefits that they might be able to enjoy. So that's one group that just makes all the sense in the world for outreach, because they're folks that have a lot in common and have that connection to place, and we can outreach to them.
Yeah, and for us, I would say we, not to simplify it too much, but we receive a lot of emails, like you guys probably do as well. So once you start becoming part of certain groups and certain email chains, there's just a lot of awareness and just really staying connected. Our resource files are super deep. And so I think that it's a lot of word of mouth. It's a lot of making sure that you stay informed. And also our team, multiple members of our team sit on different committees and advisory groups. And so just staying informed and updating each other through that, and then passing that word along to the people that we work with.
The area agencies on aging also have a role, I would say, in the different counties for convening these discussions with different groups and making sure that older adults that serve on those commissions and also professionals have the information.
Yes. And, as a reminder, ITUP, this is why we like to host different, convening some smaller, some bigger, because we want to be able to lift up all this great knowledge. And I know that there's probably other counties that are struggling with how do we even where do we begin? How do we begin? And so, yeah, I don't know if any of you just want to share a couple of words of where do people begin on this work, on this journey? Any tips? I would guess, starting with calaim and what's included and what are the local partnerships that already exist and plugging into those. But I'm open to hearing if there are any other ideas.
I think that starting with your Path Collaborative is probably a really good idea for the county or counties in which you serve, or if you're an older adult or a person with a disability, to listen in and participate and give your perspective. That's already a forum that exists. And then I also think, believe it or not, that signing up for the DHCS emails that come out every Friday and getting little tidbits about what's going on week by week is a way to not spend a ton of time, but to start getting a flow of information so that you can track what's occurring and how things are changing. And then the last idea is to sign up to be an ambassador with DHCS. That's a lot of good information as well.
I love that. I'm a big follower of like Cal Matters, KFF, the Kaiser Family Foundation. And I was like, even if I'm not working on those issues, it's just good to know what
You're in the know.
yeah, it's to stay in the know. Katrina, you want to go?
Sure. So I would say, identify if you're more of a generalist type of provider or a specialist. So specialist meaning, we primarily work with homeless individuals, unhoused individuals, or do we primarily work with youth, or you're generalists that kind of serve everybody. And so I would say whatever you are, connect with the opposite, right? Because they're going to have different types of resources. For me in particular, in LA County specifically, we have quite a significant homeless and unhoused issue going on, right? So I saw a question about that in the chat. And for me, it's been plugging into a lot of those subcommittees out in the community, different spas, plugging into LASA, and really understanding those types of resources that are out there specifically for housing and homelessness. That has been incredibly helpful. Going to things in person too. That's something that a lot of us forget about, but having a name and a phone number or an email is helpful because a lot of times it's difficult to get into your more general lines. So that has really helped me when I've faced those Friday at 4 p.m. crisis. That has been extremely helpful. And I would say, for me, it's just I use like what I call a zoom in, zoom out approach. So remembering that, like I said, calaim is a big program. There's a lot of push for data in the business aspect of everything, but also remembering we're working with people. You have to still use a tailored approach if you want this program and you want calaim programs to really work. So that's my biggest tips.
And I second appreciate the input that both Meredith and Katrina provided. I'd also add, there are, from a more maybe consumer or provider perspective of CPOs working with plans, is the Medi-Cal plans do have committees for members. The DSNPs are also supposed to have committees that represent their DSNP population, and the advocates or other community groups that serve the older adult and people with disabilities population as well, and get input on how processes or services are working or are not working. So I think those are also really good avenues to providing direct feedback. And of course, the department does put out a lot of materials and webinars on a lot of these benefits. And there is always an open forum for providing feedback and questions. So I think engaging in that way as well to have your voice heard and the experience that you are seeing on the ground lifted up as well.
I think that's so smart, Tiffany. I think going to the health plan meetings for providers and members, dedicating an hour or two out of your day to go and apply in the future, but even right now to go as a member of the public and be able to give a comment and to listen in is a really good use of time.
Absolutely. And, you know, like we mentioned earlier, just the person to person contact, you know, having those little moments at the water cooler are just critically important in building relationships and building trust, which I think is really fundamental to all of this work. Let's see, we have another question here. So it says it's partly comment, partly question. So CBOs and providers want to do the work to implement calaim to transform the health of their communities. But the overarching cry seems to be for standardization, streamlined processes so their teams can deliver services competently to garner members' trust and willingness to access services. What best practices or solutions can you share to help providers and would-be providers navigate the process of serving members? You know, what I've heard so far from you is like no wrong door, making sure that we're finding people where they're at and building around them. So centering the patient and making sure that they have support navigating the system. But any other reflections that you would like to share?
I mean, I think overall it is a team effort. I'm really, encouraged to see, the participants on this panel, the health plans involved. So it really is a team effort, and it is this is a big undertaking. We all realize that with calaim, and we do have the potential to really make a significant change in the lives of Californians. But it's also going to take a lot of work. But I think, sharing what we've lifted up so far about some of those practices, I think are like some of the first steps to getting there.
So one last prompt, and this is just based on your experience on this panel today. One takeaway that you would want people to walk away with. And with this, we'll wrap it up. We'll close out.
I would say that my takeaway is be present and create the relationships that you have with others that ultimately will be marked by care and trust, and then accountability after care and trust are established, so that we can keep moving forward and that we have each other's backs, and when there's problems, we can solve them together.
Love it. Thank you, Meredith. Patrina.
And I would say my takeaway for providers would be to really be open-minded about multiple different approaches, be involved in the data exchange framework, and making sure that we're all kind of sitting at the table together, more of that relationship building, like Meredith said, but also something we haven't touched on too much, but I think creating an environment and a culture within your agency that fosters a case management system that can survive. So what I mean by that is this work is hard. It's real hard at the field level. And so just making sure, especially for leaders, that you are fostering a positive environment through all the difficult challenges, and trying to sit in as many of these meetings and just advocate as much as you can to streamline processes so that we can kind of get out of their way in the field and help them to do the work that really changes people's lives.
Tiffany, your takeaway?
Yeah, both of them had such great takeaways. I think, in line with similar to what both Patrina and Meredith have said, is I think having that open mind, because I think what I hear often is, CBOs and other providers of ECM or community supports are trying to refer individuals for that services, trying to help their communities get access, and then running into barriers with that. And I think on the flip side, also hearing from health plans about the obstacles they also face. So I think acknowledging the real barriers and system changes that are needed to reach a more equitable future is there, and really working together to try and overcome those pieces and strategize on what can be done so that we can eliminate some of those barriers and really get people connected to these really important services.
Thank you all so much. And I would say if I had one takeaway, is just acknowledging all the great work that's happening in our community. So thank you, each of you, for that. And just reminding us that we're setting the conditions for tomorrow, right? We will all eventually be older adults, hopefully, knock on wood. And what kind of system do we want when we're older, and building towards that? So thank you all. And I think I'm going to pass it back to Maria, but thank you. And thank you to the audience. So see you soon.
Thank you so much. That was a really engaging panel conversation, and I tried my best to jot down notes, but really thankful that ITEP is creating a recording and that we'll be able to go back to this at another time. I think I'm up to introduce our next speaker, Anastasia Dotson, but before I do, I want to do a little plug, kind of thinking back to the overview at the very beginning of this session and recognizing that calaim implementation will evolve over time, and thus the needs of partners working to implement calaim will evolve over time. Our partners have launched a feedback survey. So for those who have participated in listening sessions, there's some questions to kind of get some feedback on those, but also from the broader community. Even if you haven't participated in these listening sessions, we'd love to hear, what we can do to support you in the future. What kind of resources, what kind of learning opportunities do you need? And the input that we receive will really be used to inform the next phase of this work. We really want to make sure that future engagement opportunities or future activities that we undertake are structured in a way that bring value. And I don't feel like it's right for us to assume what you all need. So I'm hoping Shirley can plop that survey link into the chat. Thanks, Shirley. And if you have a few minutes, the survey is streamlined as much as possible. It should take no more than 5 minutes, but will really go a long way in helping us to inform what the next phase of this work is. And without further ado, I'll stop talking and I will introduce Anastasia Dotson, the Deputy Director of the DHCS's Office of Medicare Innovation and Integration. I just want to express my deepest appreciation to Anastasia and her team. They've been so incredibly open to hearing from and engaging with stakeholders throughout the calaim rollout process. And Anastasia, I think I will just turn the stage over to you and give you an opportunity to share any reflections you have about early learnings and also, what the department has on the horizon.
Great. Okay. Thank you so much, Maria. And it's great to be here. And I was trying to keep up with watching everything in the chat and listening to all of the important feedback. Especially, I want to acknowledge, workforce issues kind of weave into many of these topics, as well as language access and equity. So there are so many topics, but I think I do have a few slides, but I know you guys don't really want to see a ton of slides, but I'll just run through a few things just to kind of say, okay, from the DHCS perspective, where are things at? What's the landscape of what we're looking at? But again, really want to acknowledge the important feedback and that just overall, I want to emphasize that we're still in the early stages, believe it or not, of calaim, and the tremendous amount of work that has been done there's still more to do. And so we understand that things are not exactly the way any of us would like them across the board throughout the state or for all populations. It is a work in progress. And so, it's not just DHCS, the state doing it, it's all partners together and communicating and listening. So that's just essential to trying to achieve the goals that we have. Okay, so I'll share a few slides. And I may not have the right formatting up, but I think you all can get the gist of it. So just high level, of course, these are the overall goals of calaim, a whole person care approach to address the social drivers of health, improved quality outcomes, reduced health disparities. through both delivery system transformation and payment reform, and then a consistent, efficient, and seamless Medi-Cal system. Again, we don't have all of that right here, right now, but that is what our goals are. Those are what our goals are. And so these down here kind of list out all the different pieces of calaim, but this is not the exhaustive list. And like, for example, in behavioral health, there's many pieces. And long-term services and supports, there's a number of pieces there. And so again, it's just a lot going on, and no wonder people have questions. Of course, there's a lot going on. So it's a journey that we're in the middle, toward the beginning of the journey still. But just kind of where are we at in the department in thinking about calaim and related initiatives? So as I said, we're listening, we're learning, we are monitoring. Some of that may not be apparent to everybody, but we are looking at data, we are looking at results, we are meeting with the Medi-Cal plans, we're identifying where we need to either do some technical assistance, arm twisting, or something stronger. We're refining policies because either there's more that we're learning or something that we've missed, or there's a new kind of emergence. So we're reviewing and publishing data. So we do have ways to look at data internally, and now we're pushing it out externally. We've had publishing on ECM and community supports. We have kind of a dashboard there, and then last week we shared data on dual eligibles, and for ECM and community supports, we have other data and dashboards. We had our CalMedi Connect dashboard. We're transitioning to a DSNP dashboard. Anyway, there's a lot to say there. And we're, of course, engaging with partners in forums like these and many others. Sometimes they are large public stakeholder meetings like these. Sometimes they're kind of sidebar meetings with particular folks, or sometimes they are sort of in between workshops. We've done a lot and we'll continue to do a lot because, of course, we know that the best outcomes are when we have a combination of voices, local health plan, community-based organizations, members, advocates. We do need to hear from everybody. So anyway, yes, we have data publishing, we have dashboards, we have monitoring techniques. So we have, one thing I will flag is that we have some webinars coming up, particularly for, this, as we focus on long-term services and supports, the 2024 transition for the ICFTD and subacute populations into Medi-Cal managed care. And we have, as part of that, we have ltss liaison requirements for the Medi-Cal plans. Just wanted to, put a pin in that for this group. And we do consider equity in all of our efforts. When we look at data, when we're doing monitoring, and when we get feedback from all of you. So I also really want to emphasize the tremendous investments that have been and are still being made to build system capacity and infrastructure statewide. And so if you have, and I have a longer slide deck I won't go through, but to, PATH, IPP, HHIP, just a tremendous amount of resources. And so really want to encourage all of you to, you probably already are aware, but to be hooked into those development opportunities and to think about, okay, I know there's some, transitions around, okay, we have to learn coding in order to get such and such funding to be, but hopefully as that transition occurs, it's, we're building an infrastructure so that it's a long-term way to enable that partnership between plans and community-based organizations, and a way to demonstrate to CMS on the federal side and all of the specific control agencies of how the funding is being spent and what utilization changes have occurred. The other thing we have, of course, you all know, is we have a transition coming up in 2024 for our Medi-Cal managed care plans. We have restructured and more robust contract. We have some changes in the plans that we're contracting with. We have a lot of outreach and support coming up, notices, et cetera, for members that will need to transition their Medi-Cal plan. There are continuity of care provisions. Again, this is just on the Medi-Cal plan side, and it's not for all members. It's just in certain counties, and we'll have the resource link at the end. But part of one thing I want to flag there too is MOUs. So in the CCI counties in the past, there's been there were MOU requirements, and for other counties as well with different partners. But we really want to strengthen the relationship between the Medi-Cal plans and whether it's local public health, IHSS, regional centers, all of the different local organizations that are sort of either county or county behavioral health, making sure those local partnerships have structure and they're meeting minimum requirements as much as possible. So anyway, there's a lot to say there. And we continue to roll out different calaim pieces, population health management program and service, transitional rent services. You've probably heard about that. We have a proposal in additional ECM populations of focus, the long-term care carve-in pieces for 2024, all the behavioral health initiatives, expansion of Medi plans to additional counties, justice involved, the data exchange framework. All these different pieces are happening. And I know it's like, gosh, we've already had so many transitions, but these will help. But it's a lot to keep track of. And just want to acknowledge, of course, the resumption of redeterminations. I know that was a topic. Flagging the asset test elimination that's coming in January 2024. And that's a great thing for making things simpler for people to be able to enroll and keep their Medi-Cal. We have the HCBS gap analysis multi-year roadmap that we're working on. We've got LTSS dashboard to make data more transparent. We've had dementia care aware that's launched, and looking ahead with that Medicare guide model, what are the intersections there? We have our equity and practice transformation payments and Medi-Cal targeted provider rate increases. So there is a lot going on. Last slide I have is just a list of resources, and I'll send out, make sure you all get these slides with the links, but these are just all on the DHCS web page. So, but again, going back to the fundamental point of, we hear you, we know that there's still more work to do, and we want to continue partnering with you all. And, it's sort of like each issue we have to tackle, we have to figure out who are the right people, what are the right steps to take, what are the options, and, get it implemented. And then some of it is about at the local level, like it's not all just DHCS needs to, address a policy or do something different or communicate something different. Some of it is, what needs to be done at a particular local level, or what is the need there, and how can that need get better addressed. So anyway, I think that's kind of the gist of my comments. And Maria, did that kind of hit the mark as far as what you were looking for?
Yeah, absolutely. I think it did. And I would invite folks that are joining the webinar today to submit your questions and comments for Anastasia. I've got a couple that I can just start with. So I want to circle back about this question that came up earlier, which was a question about outreach to beneficiaries. And I think that this is a topic that I'm particularly interested in, just having to navigate my own healthcare and having to be that advocate and kind of ask for services that maybe weren't presented to me. But from the department's perspective, who is the appropriate entity for engaging and informing beneficiaries about calaim and making sure that they understand the new benefits available to them? And are you aware of any efforts that are either ramping up or ongoing to bring them into the loop?
Well, so calaim is many, many things. So I think it's more about, are you thinking about outreach of people who might be eligible for community supports? Or is it outreach on like a certain long-term care carve-in? Or, that's where probably we should talk more specifics. And, so like if it's enhanced care management, one of the things that we have talked to the plans about and we continue to talk about is what are the ways that they can identify who may be eligible or could benefit from, and that actually ties in with, population health management and risk management and stratification, so that the health plans, they have data, and we want to make sure they are using that data to, identify folks who could need those services. But that's not the end of the story, because as you have pointed out, of course, there's folks who may not show up in that utilization profile, but could well benefit from the services. So that goes back to, working with community partners and getting sort of local outreach communication channels, fully developed, and referrals.
Yeah, and I was definitely, I think in my mind, I was thinking of the example of, community supports and having these supports that are available, but maybe not knowing that they are out there in the community, and who's responsible for engaging with beneficiaries to say, hey, you might be able to leverage some of this. And it sounds like, correct me if I'm wrong, it sounds like that is maybe something that CBOs might be tasked with moving forward.
I think it's all, partnerships with the health plans. And the other thing is, so we, again, published the 2022 data, we're looking at the 2023 data, and we have been, certainly having conversations with health plans to say, how can we increase utilization? And we've had a good dialogue with them to say, okay, sometimes there's, kind of misunderstandings on some of the data pieces. And then now, oh, okay, now that we're ramping up, yes, now our numbers are going to look a lot higher. But that is still top of mind for us, is increasing access and utilization uptake of community supports. And I think it's, I don't think we have like a statewide, kind of one size fits all, but we really are pressing the plans pretty hard.
Fantastic. And I know you're probably seeing this too. There's a lot of chatter in the chat and the Q&A about workforce shortages that are, of course, heavily impacting the healthcare and social services delivery across the board. And I'm wondering if you can share any specific state efforts that come to mind to bolster the workforce. And one caveat too, I think, is that as Connie raised, that in order to have robust options for community living, we need a strong direct care workforce. And even though direct care workforce is maybe not under the umbrella of DHCS, are there any efforts to partner with sister departments to kind of work on these intersectional issues?
Sure. Yeah, we know, like in our HCBS spending plan, we included workforce initiatives there, and we know that it's a priority for the administration. Like you say, many different departments are working on initiatives there, and there's, in some ways, it's even a national issue. So, thinking about ways that whether it's CMS or other kind of federal agency support that can help us, but absolutely acknowledge the issue. And there's not a single solution, and it is quite a challenging problem.
Yeah. Anybody else want to jump in with questions? Okay. Well, I think before we turn it back over to Crispin to close this out, I think it's just really important as we're having these conversations to underscore and acknowledge that calaim is really a multi-year initiative. It has a multi-year nature for implementation. And so this incredibly bold vision is not going to be achieved overnight. I think it takes this communication, this back and forth, and really appreciate the department and being so open and willing to engage and hear that feedback. But it's going to take this kind of engagement moving forward to really advance and bring that vision to life. And so really appreciate your time, Anastasia. And I think this is probably where I'll pass it back to Crispin to close us out.
Thank you.
Thank you, Maria. Thank you, Anastasia. I also just want to take this opportunity to thank all of our speakers today. And of course, our co-hosts today, the California Collaborative and Chapman Consulting. I do want to take the opportunity to thank the ITUP staff that helped put this together. Couldn't do it without you. Love my staff. And lastly, I want to thank all of you, our audience. These sessions are important because of the great questions that you brought up and the great insights that you shared. So I encourage you to stay connected with us, and we look forward to seeing you in the near future. So thank you all, and have a good rest of your day.